Yes, I think we'll move on to the last short presentation from Dr. Vineet. Vineet is, where is this? Yeah, this introduction slide. Yeah, he is an interventional nephrologist and transplant physician at INHS Aswini Hospital, Kolaba, Mumbai. And he is very much into various aspects of clinical nephrology and epidemiology and social media. I think that is his strength. And he has been getting involved in INForm, and he is trying to take us into, extend our visibility by putting us into other social medias as well. Welcome, Dr. Vineet. And after you can share your slide and tell your work which you presented in ASDIN, which was just over now, about your novel technique of extending the tunnel in case of extrusion.
Can you see my slide?
Yes.
Good evening, everyone. Thank you, sir, for the kind introduction. Yeah, thank you, sir, for the kind introduction. And I truly thank INForm and Dr. Balasubramanian, sir, who has been an inspiration for giving me this opportunity to present my work. I feel really proud and feel honored to be presenting my case or my work in front of so many stalwarts and senior nephrologists who have been teachers and really experts. So I'll try to do my best. So we present a simple case of managing cuff extrusion of tunneled catheter, that is a catheter exchange with elongation of tunnel procedure, or the CEET procedure, which we have named it. So cuff extrusion of a tunneled dialysis catheter is not so uncommon thing, and with a reported incidence of about 2.5 for every 1,000 catheter days. And some studies have quoted incidence of being about 10 to 15% of the common complications of a tunneled catheter. And most interventionists would have seen it in their experience. It is generally commonly seen in obese females, people who have lost their cutaneous fat, children, individuals with short neck, and people with previous extrusion have more chances of having a recurrence. So the predisposing factors can be a short tunnel. Sometimes when the tunnel is too acute or too straight, in those cases, not using an anchor suture, tunnels created over breast tissue have more chance of getting extruded. Few catheter types may cause more chances, and underlying tunnel infection. So generally, how we all have been managing it are mostly temporary options. Like the easiest way is to push in the catheter or the cuff back into the tunnel, and obviously there is a chance of infection, and it generally recurs. People have also tried suturing the catheter or the cuff to the skin, but again, it's a temporary method. And the most commonly and generally done thing is to put in a guide wire and exchange a new catheter to the same tunnel. But sometimes the tunnel is short, and this has got high chance of recurrence. So generally what we've been taught is that the only definitive method of doing it is to remove the existing catheter and reinsert a new catheter with a new tunnel, and if required, a new venotomy. But the problems with these modalities are, as we discussed, the temporary measures recur often, and sometimes after we remove the guide wire or when we are doing a new venotomy, the chances that the vein is lost after the catheter is removed. And in a older patient, in a patient who had a prior infection or a tunnel infection, there is some scar tissue, and space may not be adequate in all cases. And of course, sometimes it requires two procedures. The procedure may be longer, more invasive, more pain, etc. So this thing has I had given multiple thoughts to this thing, that such a simple thing, the catheter may be working well, only the cuff has come out and it is functioning fully. So do we have to remove the full catheter and do a fresh puncture and do it again? And the literature, to be very honest, does not give any specific due recognition to this fairly not so uncommon problem. And there haven't been any obvious studies or any obvious reports of managing such cases. So we needed a specific treatment or some better way of handling these cases. So we would take this index case, a 52-year-old female. She had been on a dialysis from a peripheral center for the last 4 years, had multiple access failures, presently was on a right IJV tunneled catheter for the last 5 months, and she got the cuff extruded 1 month back. However, as the flow was good, she continued with dialysis, and she came to us for a normal review. And she told that for the last 1 month, the technicians or the team were managing by pushing in the catheter. They also tried suturing the cuff or the catheter to the skin. So on assessment, seeing her risk factors, she was a short, obese lady and had a short tunnel, which a relatively short tunnel. So we checked her cultures were sterile and there was no obvious tunnel infection. The flow was good. And prior to the procedure, we also checked for any fibrin sheath, so there was no obvious fibrin sheath. Her left IJV was thrombosed, so we preferred to do a CT venography just to exclude any SVC or any other CV stenosis or thrombosis, but it was normal. So we went ahead with the procedure. I will share a short video of the same. So the patient was taken in the cath lab, cleaned and draped. So 2 J-tip thermo-guide wires were passed through both the ends and they were secured within the IVC. Thereafter, the catheter was removed with both the guide wires in situ. So this is the guide wires are inside and the catheter is out. Subsequently, we created a new tunnel from the exit point of the previous tunnel laterally. So a new extra tunnel was created with the trocar. So you can see the new tunnel has been created and it was inserted into the new tunnel, threaded over both the guide wires, pushed through the guide wires into the right atrium. So the new tunnel is in situ with the elongated and longer tunnel. And this is how it looks like in the end. I'm sorry. Yeah. So the key advantages or the key benefit of this procedure was it was a relatively simple procedure done in a single setting, and we could use the same tunnel in a partial way. No
Dr.
fresh.
Vineet, sorry to interrupt. If you could show the video again, please.
Yes, sir. The patient was taken up in the cath lab, was cleaned and draped, and 2 J-tip thermo-guide wires were passed through the both the artery and venous ends, and they were secured into the IVC. The catheter was removed, and both the guide wires were left behind. So this is both the guide wires were inside, and the catheter is out. So, so from the lateral point of the previous tunnel, a new tunnel was created using the trocar. And after that, the new tunnel was inserted through both the guide wires. The new catheter was inserted through both the guide wires, and it was railed in and secured into the IVC. The guide wires were removed, and this is how the new catheter with the new tunnel looks like. So the basic advantage of this procedure is that we could do it in a single setting, and we could use the same tunnel. No fresh puncture was required, and of course there was less pain and less invasive. And to prevent recurrence, we slightly made a longer tunnel, in fact elongated the tunnel this time. And the previous tunnel maybe was quite superficial. The cuff was quite superficial. So this time we made sure to keep it around 1.5 centimeter deeper from the exit point. And based on the requirement, if the tunnel is good, we can use the same length. If it is shorter, we use the additional length. And we can sometimes, if it's a straight tunnel, we can make a curved tunnel to prevent extrusion. And we can also use one guide wire. For me, using 2 guide wires gives more stability. And I would say that in my initial cases, I was tempted to use the same catheter. I used also in 2 cases. One patient was around 2-day-old, one around a fortnight old. So in one patient, I got away. The second patient, I had an infection. So I had to give an antibiotics, and which subsequently recovered. But thereafter, I strongly recommend, and we also have been doing, please use a new catheter and don't use the old catheter. It is not recommended. So the precautions are that the key precaution is that infection has to be ruled out. Any form of tunnel infection or a catheter-related bloodstream infection has to be ruled out. And while doing it, we can check for a fibrin sheath. If it is there, it has to be corrected. Any CV stenosis or any thrombus in the catheter. Any defects in catheter type, maybe we use a different catheter. And so we can commonly do X-ray chest, basic cultures. And if you are suspecting a CT venography, CV stenosis, we can also do a CT venography. And as I said, the main contraindication or what we should avoid is in case of an active infection. And in case the tunnel is created over the breast tissue, we should take it through a different site. And in case there is a fibrin sheath or a proximal SVC stenosis or CV stenosis, then in that case, that has to be corrected first, and then this procedure may be done. So we have done about 7 to 8 cases so far, and this is just a case. She's 62-year-old female, diabetic, dialysis for the last 3 years. Her right side IJV was thrombosed, multiple AV fistula failures. She had cuff extrusion for the last 3 months. She was somehow continuing with that. And you can see the tunnel is actually looking very short. And she had lost some weight. So there was minimal subcutaneous fat. And we had a lot of difficulty in convincing her that it has to be changed. She was initially unwilling, saying that the flow is normal. Why do you want to change it? So anyhow, so we convinced her and we could change it. And after doing the procedure, we could insert the catheter. It looked something like this. So to conclude, I would say the learning points, we should firstly try to prevent a cuff extrusion by first and foremost doing all procedures under fluoroscopy. Blind procedures often land up with short tunnels and the tunnel length isn't adequate. So they should not be done. And avoid using the breast tissue or the area over that to make the tunnel, because sometimes loss of fat can cause it to extrude out. And try to give a minimal curvature to a tunnel. And despite all these, if it still occurs, try a procedure, the CEET procedure. So my talk won't be complete without thanking my cath lab team and the cardiologists who have always stood behind providing support, and my 2 intervention gurus who I have always looked forward to, Hemant Mehta sir and Valentine Lober sir, and I keep troubling them, and I will keep taking their opinion in future. I would conclude by this slide that we have just launched our new page on Twitter with a new Twitter handle, INForm Nephro. We had some 60 odd followers in one day. So please, all listeners and others, please pass on and join this. And we would be looking for suggestions, also adding videos, sharing videos, so to make it more educational and more informative. Thank you very much. This is our institute, and with a nice seaside located hospital in South Colaba, so in Mumbai. So thank you so much for the patient hearing.
Thank you, Dr. Vineet. One question, anyway, you agree that changing the catheter is always better, than using the same catheter for fear of infection. In what way making another, a regular puncture and putting in another catheter, what is the issue you foresee in such circumstances, and what do you gain by this?
So in an ideal setting, doing a new venotomy would be more appropriate, but it adds to the procedure. Then sometimes doing a new venotomy, sometimes if you remove the guide wire from the previous one, so if the veins might collapse and we might lose the previous vein. So we have lost sometimes by removing the previous catheter, taking a break and doing a fresh puncture and doing a fresh tunnel. So that becomes a difficulty. Sometimes in short people who have a very short area in that place, making a new tunnel, sometimes there is no space, there is scar tissue, so that becomes difficult. And above all, if you can do without a venotomy, so there is no harm in that.
Yeah, thank you. Then one small issue, say if you have appropriately placed the tip, in the ideal place, And if you see the cuff extruding and it is lying outside, that means the tip should have gone up to a certain extent. So by extending the tunnel, your what will happen to the tip of the catheter? Won't it be
the common mistake we commit is that we always focus on the tip, and mostly while doing it under fluoro, the tip generally is in the mid RA, so we are able to place it correctly. But if the cuff is very close to the exit point, say less than 1 centimeter, so in obese patients or who have loss of fat, there is a possibility it might slip out. So even if the tip is inside, if the tunnel is not made with the appropriate length, if it is short, so it might slip out or it might be just at the margin of the cuff. So while doing the procedure, I feel that we should measure the length properly and plan and give some importance to measuring the length of the tunnel. After, of course, seeing the tip in the RA, we should also try to keep a good length of the tunnel. So not very much, but at least 1.5 centimeter, so that we have enough margin for the tip to stay inside, for the cuff to stay inside the exit point.
Then that brings back the question, the distance between the cuff and the exit site.
Yes, sir.
It is shorter, they claim that epithelialization and sealing off and chances of infections are less, something like that. And if it is quite away from the exit site, at least for PD catheter also they say something like this. Does that argument hold good?
Surely, sir. We should have an ideal thing of 1.5 centimeter or maximum 1 to 2 centimeters. But sometimes for adjusting the tip, say suppose the tip is adjusted too deep into the mid RA, people have a tendency of pulling the catheter out a bit. So in such cases, sometimes the cuff may not be in the exact position. It might be too close to the exit point. So the key thing is that the tunnel should be of exact length, and we should spend some time planning the length of the tunnel.
I think Dr. Vineet, I just had one point. Whenever the cuff is out of the exit site and we had to do an exchange, the other thing what we could consider, this is just my school of thought, is using a retrograde catheter.
Absolutely.
That way, probably all these things can be avoided, because the advantage with the retrograde catheter is obviously you can definitely plan the length of the exit site, and probably this maneuver might not be needed in case we use a retrograde catheter.
Absolutely, I totally agree with you. In fact, I have used retrograde catheters, but keeping aside the cost, so it is certainly a very good option.
I have if I can ask Vineet, 3 points I needed to make. The first thing, ruling out tunnel infection. One of the things, these people, when the catheter slips out, it's very hard to see X-ray because it's being washed off. But one of the things I do is I use POCUS, point of care ultrasound, and I use it and I put it on the tunnel. If I see a black area around the catheter, I know there's a fluid collection there that we have missed. So that is most likely a sign of infections. That's one of the things I do to pick up an occult tunnel infection. That's the first thing. The second thing I foresee is when you make a longer tunnel, is it may be difficult to take out the catheter later on because the cuff is gone more inside the chest, and you might have to do a cut down to take off the, you might need a cut down to release the cuff. The third thing, I'm sure you answered this during ASDIN, and I may have, during ASDIN is, when you make this new tunnel, do you put a stitch, where your tunnel is coming out at the old exit site?
Yeah, if I am making someone's speaker is on, please kindly check. So so if I'm making a new tunnel, so that area remains the open point. So I put one stitch at the area. I do that.
Okay. Yeah. So based on that, that makes it sense. So in this lady that I'm seeing this picture right here, I just feel that this tunnel may be coming onto her breast tissue, and so I would have argued and said, go more laterally. Yeah. So right.
I did the tunnel something like this.
Tunnel.
So the tunnel we did something like this. We entered through here, laterally placed.
Which is lateral? I think lateral is where a hand is, right?
Yeah.
No, she is in a, the photo has been taken from a sleeping position.
Okay.
Okay, it's hard to understand. Okay.
But
sir, I had one more question for Adrian sir. So is it always essential that the cuff should be below the clavicle?
Oh yeah, I would like it to be below the clavicle. If it is up there in the clavicle, it will irritate the clavicle. It will always be red. Patients are never going to be happy, from what I've seen. And plus, how are you? The tissue is very thin out there.
Yes, sir.
So it can cause a lot of irritation, and I don't know, maybe even make the skin thin and open up a wound. So I always like it below. That's just my feeling.
And removing the catheter, how often you just pull it out, and how often you make a cut down and make the cuff come out?
Actually speaking, all catheters, the very rarely a cut down should be required. So if the catheter has been placed fairly in a normal way, so just pulling it, giving some traction and dissecting it from the exit side should be enough. So cut down we should try and avoid unless it has been placed very deep, say, but that is generally not done nowadays. So I think we should avoid a cut down because that area has got several vessels, and so there are chances of injury. So I feel at the exit point only, exit site only, we should dissect, give some local anesthesia, dissect, maybe give some traction and do it. And it happens in almost all the cases.
Vineet, if you want to prevent cuff extrusion, and if you advocate, longer tunnel, then just dissecting at the exit site may not help in the removal.
By speaking of longer tunnel, I actually mean to say a properly correct size tunnel. Longer tunnel may not necessarily mean a very long tunnel, because in that case, the cuff, of course, would be quite deep from the exit point. So often what I was saying is that the commonly mistake, in fact, even I have done in my initial days, is that we place the catheter very deep into the tip becomes quite deep in the RA, and to prevent that, we try to pull it out. In that case, our tunnel adjustments go wrong, and often the cuff is left behind quite at the point of the exit point. So they are the cases who generally go wrong. So if we measure it well prior to the procedure, generally that problem should not happen.
Yeah, I always habitually have a long tunnel. So mostly I end up putting a cut down well removal. So it is quite deep.
I think, yes, sir. One more thing is that I felt that probably these tunnel catheters could be customized for our Indian population, in the sense that the distance between the cuff and the hub could be little shorter, so that the entire hub is through the skin. The hub is present exactly at the exit side. That way we avoid the cut down procedure, and we also prevent infections, because some of the population with not so high education or awareness about the exit site infections, we feel that burying the entire space between the hub to the cuff might help us in preventing infections.
Dr. Vineet, I have a small suggestion.
Yes, sir.
We have seen perm catheters coming out spontaneously. What we found out was the sisters who clean up the dressing, if you fix the wings to the skin, they tend to lift up the catheter, that way the catheter slowly drips, comes out slowly. And I feel that is one of the important steps to prevent this slipping out of the catheters.
It's an absolutely valid point, sir. In fact, my patient whose catheter slipped out on day 2, so it was because of traction. So they should actually anchor the dialysis tubings to some cloth or something, or put a tape over that to prevent the traction from happening. So firstly, we should put an anchoring suture. Despite that, so sometimes because of the pull of the dialysis tubings and all, that might slip out. So what you're saying is quite valid, and our staff should be very well trained, especially in the initial few days when the cuff hasn't fibrosed and it is still fresh. So this is a common occurrence. So we should train our staff to prevent this.
So one question to the panelists, please. Of late, I started applying betadine over the cuff, proposing it could act as an irritant, causing it to fibrose more easily and more rapidly, which might at least theoretically prevent it from coming out in the future. So, you think like that a valid thing to do? Like, what is the experience?
What is that again, Venki? What do you apply?
He's applying
Betadine.
betadine.
At the time of catheter insertion, we apply a bit of betadine over the cuff.
Venki sir,
So
is it
proposing
betadine
it could act
ointment
as
or
an
the
irritant.
betadine
No, it's
lotion?
a lotion. Yeah, lotion.
Okay, yeah, the one you use to clean the skin.
Betadine is a non-sclerosant, and what you are saying is right. Even the surgeons say that putting betadine within the tissue causes more fibrosis. I personally do it while doing my CAPD catheters, but in tunnel catheters, I have generally not done. All these perm cats, I have not done. In CAPD catheters, I have done it, and maybe it helps, maybe not, but I do it.
So in another scenario where I had really seen it helping is in post-transplant patients with lymphocytes. So that is one commonly used sclerosant to sort of, no?
Yeah,
That helps.
many centers routinely put in betadine, post-op to prevent lymphocytes. Then coming to this, Dr. Vineet, exchange of catheter, you think this BART catheter with the stillet, that will make the, it will be more stiff, and would it be more easier to use that?
True, sir. The BART.
Now you are using 2 wires.
Yes, sir.
That has a slightly stiff stillet, and so
either the BART one or the Covidine's HSI silver, they also have a stillet with them. So any one of these would make it more easier, and it will slide in even more easily. Quite right. So it will be more easier to do with that. But somehow, I'm not officially commenting, but I have seen that the BART catheters, the ones, the glide paths, I may be wrong. In those catheters, I have seen that it is more common. The cuff extrusion, maybe I'm wrong, but somehow I have seen that. So I would ask the comments of others that have they seen something like that. That glide paths are generally more commonly.
Actually, the cuffs in glide path is slightly different from other catheters because it is slightly conical. It is not a rectangle. If it has it is easier to tunnel in when you insert the catheter. But logic and common sense tells me that pulling out may be difficult. I mean, you understand the structure of the cuff in BART is. So I don't know.
So anyway, couple of points. You're using 2 guide wires for more strength. Is that what you're using it for?
Yes, sir.
I see. So my favorite catheter is a glide path. Glide path to me can do no wrong. I love it. It goes in smooth. It comes out just as smooth. So I have no problems with the glide path. That's just the point I wanted to make. The other thing, I was just surprised. You all said that you all stitched the hub to the skin, and in spite of that, with the traction of the when you do the dialysis lines, it pulls the catheter out.
Yeah.
I mean, it's all bad etiquettes in the dialysis room. The heavy blood lines hang. And,
but how you have stitched the hub to the skin? It's still able to yank it. I find that hard to understand.
It can't be very strong, no? Your thin skin, and many times they have to re-suture. That's what.
Yes, sir.
You mean
the suture also. Yes.
Yeah, that suture doesn't remain forever.
Yeah.
Many times,
that I understand, but by at least 2 weeks, the suture will still remain. At least in my experience, the suture still remains. Nothing happens. So I'm just concerned, are we not suturing properly, or are we suturing with a material that will dissolve in 2 weeks or something? I'm just trying to understand this.
The suture stays, sir. But what happens? The dialysis tubings. So with the blood in that, so they fairly become have some weight. If that causes a traction over the catheter, there is a possibility if the cuff is quite close to the exit site, it might trickle out, or it might dislodge.
A very interesting observation. I have to go see this for myself here.
It sort of directly correlates with the care given by the dialysis technique.
That's true, sir. Quite true.
Yeah.
Sir, I had one more. Yes, sir. Please go ahead.
No, Dr. Kasi, he is so meticulous in following a patient with TC in his dialysis room. And we all don't seem to do such strict surveillance. I mean, from our part, we don't. I felt guilty, after his presentation that I wasn't doing enough because I hardly interfere in technicians' work and mostly they are not very careful. So that is why Adrian is not seeing much of extrusion and pulling out, and we do more. See, most of this cuff extrusion, you see that the sutures would have been gone and they might have been resutured promptly. They'll just put in the plaster and send them and they come back even more catheter lying outside.
The other thing, Vineet, is you cannot use this procedure for a freshly placed tunnel. Even if it's exposed, exudes in weak, you cannot use this because the catheter won't go through the tunnel.
But it went in, sir. My patient, we tried that. It actually went in. The shortest period was about 5 days, was about 3 days. So it went in. I put the same thing, took two guide wires, it went in.
That's fascinating because, the tunnel takes some time before it matures. And we have tried pushing, it will not go. Maybe you can put a smaller diameter catheter. I mean, the BOD is a 14.5. Maybe there's a smaller 14 French, maybe. But still, there'll be so much friction between the catheter and the tunnel, it will not go.
More easier if it goes in, the cuff will come out more easier pretty soon.
I had one more question for all the senior panelists here. Any experience with the tunnel catheter in azygos vein?
Take it out.
No, sir, recently I had a patient.
Instances, there have been instances, and Sampath showed on demo when the tip is slightly, medially turned at the carina level. That is what should give you the suspicion.
Basically,
unless the patient has dextrocardia, remember that.
Okay.
Then it will go in the opposite. It will cross the midline.
No, I was trying to be too optimistic in the sense that recently I had a patient with multiple access failures and all veins were CTO, right? The right jugular, left jugular, and then the innominates, all were CTOs, and the only vein that was open was the left azygos. So I was trying to be little optimistic in the sense that since we have no veins available, because of the central vein occlusion, has this azygos dilated so much that it can accommodate a tunnel catheter?
Yes, you will have to use it then. If you're getting good flows and there is no alarms beeping, then you're good. You have no choice. You're right.
Exactly, sir.
Unless you went in the groin. Did you check the groin? I'm sure you checked the groin.
Actually, this patient had a tunnel catheter in the groin for 3 years, and then she presented with no flows through the groin catheter.
Fascinating.
These catheters can take any course. Actually, in one of the early meetings of INForm, I presented a left side tunnel catheter going into the right, the azygos. Then, going back to the body fluid assessment, and Manish, are you there? Dr. Manish? See, we nephrologists are supposed to be very specialists in fluid assessment, but we are not, we are so overconfident probably that we don't seem to be using POCUS as much. But should we be advocating more use in dialysis room and in wards and in big institutions? Chandigarh, I was going to ask him how frequently they use and all that.
I think it would make sense because, as Abhilash showed, the sensitivity is very poor in the early stages. Towards the end, like I tell people, even Stevie Wonder, a blind man can tell you patient is short of breath and his volume overloaded. But it's in that gray zone or the early zone where you are not sure. You think you know everything, but you don't. Maybe that's the point where I think ultrasound may help us.
Yes. I think if there aren't any more comments to add, I should thank the speakers, Dr. Abhilash, Arun, Vineet, and the panelists, and all people who attended today. And I think we'll call it a day. Thank you. Thank you.
Thank you. Thank you.
And if there are, if you can add suggestions, for as Adrian was telling, each time there should be one a sort of a clinical case to discuss rather than only lectures, so that it becomes more. For that, I need people to come out with clinical situations. So
Yeah.
let us try to make it like that.
One interesting case, all of us will get involved. That's
Yeah.
enough.
Yes, absolutely, sir. Yeah.
Okay, Girish, we are expecting from you next.
Yeah, I do have, sir. Probably, I just had a small request and suggestion for Bala, sir. Can we consider having only one topic every month and then one clinical case, so that the discussion becomes better? Just a request.
Actually, this month, if you see, it was only one topic.
Yes, sir.
The Arun's presentation was going along with.
Yes, sir. Yes.
And Vineet, I wanted to bring him in quickly with this ASDIN.
Yes,
Very I agree. We'll do that. We'll make one lecture, and the rest should be discussions on cases.
Thank you, everyone. It's always a pleasure and academic feast every month happening here.
Thank you.
Thank you.
Thank you.
Bye, guys.
Good night.
Bye, sir.
Good night. Good night.
So good night, sir. I'm stopping the recording here.
Right.
Okay.